we can move forward with developing a network for patients with Leber's optic neuropathy in this country. And certainly, the society has moved a long way. Last year, about 18 months ago, we had the first patient meeting in London at Moorfields Eye Hospital, and now we're here in this great conference setting here at the Muller Center, and it just tells that there's a clear momentum towards expansion. I'm really hoping that this is the start of a great adventure with our European partners. It's great having members of the French organization here today and also the Swedish organization. And what I want to do in this first presentation this morning is to talk a bit more about the disease, how it presents, what we know and what we don't know, and also perhaps give you a bit more of a flavor of how we approach the diagnostic workup when someone is suspected or has been confirmed to have a diagnosis of Leber's optic neuropathy. And there's a lot of people in the audience here which I know very well, going back many years, someone I saw even yesterday in my clinic. So it's great to be here with friends and also trying to make new connections because it is challenging to do work in rare diseases, and we need to collaborate both with academic partners and also with patient organizations. So my background is I'm an ophthalmologist. I did most of my clinical training and my research training up north in Newcastle, which is a great place. I really love this part of the work, except it's a few degrees colder than here in the southeast. And when I was doing my clinical training, I had the opportunity to meet up with two very inspiring mentors who are still helping me as I go along. Doug Turnbull, who's professor of neurology in Newcastle, and then Patrick Yu who's also a professor of neurology here in Cambridge. And I became interested in the field of mitochondrial research, and when I started my training in ophthalmology, then I focused very much into understanding more about how mitochondrial disease can affect the eye. This year I moved to Cambridge, and it's been great in terms of connecting again with some of my colleagues who moved down with Patrick Yu, and I also have a link with Moorfields Eye Hospital in London, and I'm hoping that this cluster of experience and expertise will help in our future research targets with Leber's optic neuropathy. So in terms of my financial disclosures, I'm a consultant and a coordinating investigator for the GenSight LHON trials that we're going to talk a bit more about this afternoon. And what I'm going to do in my presentation is split into some distinct sections. I think the first thing I want to talk about is, because there's a varied audience today, is how do we see and how does LHON affect the optic nerve at the back of the eye? The second topic is more broadly about mitochondria and how genetic mutations in the mitochondrial genome can cause human disease. Then I'm going to talk more specifically about the clinical features of Leber's optic neuropathy. I'm going to talk a bit more about what triggers loss of vision in this condition, and there's still a lot that we still do not know about this specific part of Leber's optic neuropathy. And finally, which is an important question that gets asked many times in clinic, is whether, when you have a mutation in the mitochondrial genome that causes LHON, whether it only affects the eye or whether it can have other clinical complications from it. So the first thing is, how do we see, right? So this is essentially what you would see when you look at yourself in the mirror. You have the eyelids here. You have the white part of the eye. This is the colored part of the eye that we call the iris. And then this is the pupil. And the pupil is really the aperture that allows light to go into the eye. And then this is just a cross-section of the eye here. And behind the colored part of the iris, you have the crystalline lens. And as we grow older, the lens becomes thicker and more yellow, and eventually, some of us will develop cataracts that will need surgery. And the reason why we need a lens is because it allows the light to be focused onto the back of the eye. And the back of the eye is lined with something called the retina, which is the photosensitive layer, which allows the light energy to be converted into an electrical signal. And if you look at the retina, I'm not going to go over the complex structure, but it's a really beautiful way of organizing all these cells, because all these layers have a specific role to play. One layer will absorb the light, one layer will produce the electrical signal, and the important layer for Leber's optic neuropathy is the retinal ganglion cell layer. And the reason why this is important is because the axons, the little outgrowth from the retinal ganglion cell will converge at the back of the eye to form the optic nerve. So when you look at the optic nerve here, right, it consists of 1.2 million retinal ganglion cells, and the axons of these retinal ganglion cells form this little bundle, which conveys the electrical signal from the eye to the brain. And the way I explain this, which is actually factually correct, is that the eye is a very sensitive camera. And this camera will produce the signal, which will then go at the back of the brain here, where the visual cortex is located. And the visual cortex is the computer that is going to process all these complex signals. And in between, you have the optic nerve, and the optic nerve is the broadband cable that connects the eye with the visual cortex. And in Leber's optic neuropathy, it is the optic nerve which is going to be damaged and which is going to lead to loss of vision. So if there's anything which is unclear, please feel free to raise your hands as I go along. So this is what we see when we look at the back of the eye. The golden yellow circle here is the optic nerve. And outside, you can see here all these blood vessels coming out and diverging. And you need these blood vessels because the retina needs a lot of energy, a lot of oxygen, a lot of glucose to work properly. And if you look at the retina here, right, you will see I've highlighted an area here, which is called the macula. And the reason why this area is very important is because this is what subserves central vision, your central 20 to 30 degrees of vision. And in Leber's optic neuropathy and other mitochondrial diseases, it is the macula which gets affected the earliest, and the more severe impact is on this specific part of the retina. And if you have a problem with your macula, this will affect your central vision, and this is the reason why people are unable to fix in the middle, because you lose that central vision which you need for reading, to look at people's faces, to be able to drive, for example. So this is really a very brief overview, of the structure of the eye and the optic nerve and how it can become affected in Leber's optic neuropathy. And I think the second thing which is also quite challenging these days is there can be quite a big gap in between a patient presenting with loss of vision and eventually the genetic diagnosis is being made. And the reason for this is manifold, is because it's a rare disease. People don't think about it in the first place, and also there is a delay in terms of getting the genetic test, because it can take up to 3 to 4 months before you get a confirmed genetic results back in your clinic. But I think the other thing also which can be quite strange to people coming to an eye department, especially when you've just lost your vision, there's a lot of anxiety about what the problem might be, is the eye test that you get done when you come to see me in clinic. And I just thought I would mention this very briefly. So I think the first thing, unfortunately, is a lot of pressure on the National Health Service these days, right? And you will find that when you come to see me, that the clinics are very busy, there can be long waiting time, and I can really apologize for this, but that's the way of the world at the moment, really. And the first that you will get done is you will have your vision checked. And this is a standard Snellen chart, right, with a big letter at the top and small letters as you go down the chart here. And very often you'll also get your eyes checked by the orthoptist or the optometrist to check the best level of vision. Sometimes we need to put some glasses to be able to get your best vision. And sometimes also we'll check your color vision. And the reason why checking your color vision is important is because it gets affected quite early in various forms of optic nerve diseases. So don't find it strange if someone opens a book in front of you and asks you to read these numbers. There's a reason for this, because it allows us to get a much better appreciation of the function of the optic nerve. And almost always you will have drops put in your eyes to dilate your pupil, and it can make your vision a bit more blurred. And you should not worry about this too much, because within 4 to 6 hours the drops will dissipate. And the reason that we do this is it gives us a much better view of the back of the eye. And by having much better view of the eye, not only can we confirm our suspicion of Leber's optic neuropathy, but it allows us as ophthalmologists to exclude other possible reasons why you might be losing your vision. When we talk about field of vision, it's quite a weird concept, right? And I thought the best way to explain this is by using our little friends here, the minions from this kind of very funny cartoon, really, right? So the first thing to consider is how much vision you can see with only one eye. So if you close one of your eyes, right, you will find that roughly speaking, you have 150 degrees on the horizontal meridian, and about 120 degrees on the vertical meridian. So that's what you can see with one eye. Obviously, if you have two eyes, this will overlap, and this will give you a much wider field of vision. So when you come to see someone in the eye department, you will have your visual fields checked. There are two ways of checking this, either with a Gorman perimetry or with Humphrey perimetry, named after Mr. Gorman and Mr. Humphrey, who devised the machine. And the reason why this is very helpful is because it allows us to further progression of the disease, right? So this is the visual field from an actual patient with Leber's optic neuropathy. And you will find here, this is the left eye, this is the right eye, this is as if you're looking yourself. And you will find that there's an area in the middle here, which is blacked out, and that's the reason why someone can't see very well, really. And this is reflected here in that cartoon. And the other test that you will have done very often is you will have a test called an optical coherence tomography imaging. And it's really been very useful in our field because it allows us to image the back of the eye non-invasively, so no needles, nothing involved. And it gives us a very high resolution of the retina. And it's fantastic because you can see each retinal layers in high definition, and you can measure the thickness, and this tells you whether things are progressing as the disease evolves. So this is about the tests that you will get done in the eye department, not only at the stage of having diagnosis, but we're also using these tests as part of the clinical trials that we're doing on Leber's optic neuropathy. So what about mitochondria and human disease? So most of you will know that mitochondria are present in every cell in the human body. And it's been very much likened to a battery because this is what it does. It produces energy, and the energy is used for all these various functions that the cell needs. And what happens in mitochondrial disease is the battery runs out of energy, right? And when it runs out of energy, the obvious consequence is that the cell does not work properly, and some cells in your body are more sensitive to a loss of energy. The other thing which is quite unique about mitochondria is that they have their own genetic code, right? This is part of a long evolutionary history, but mitochondria have their own unique genetic code, and it's a very small circular DNA molecule. And what is really interesting about this is all your mitochondrial DNA comes from your mother because the mitochondrial DNA which is present in sperms get degraded. And this is very important because primary mitochondrial disease only goes down the maternal line. So if a man has a mitochondrial DNA mutation, he can't pass it on to his children. And in terms of the number of genes which are encoded by the mitochondrial genome, it's quite small, only 37 genes in total. But because all these genes have been preserved through a long period of evolution, they're all crucial. You can't lose any of these genes, and all of them, if there's a problem, will lead to some form of human pathology. And over the years, more than 200 mutations have been identified, so-called spelling mistakes. And each of these mutations can cause a specific cluster of clinical features. And I'm going to talk more about the mutation that can cause Leber's optic neuropathy. So mitochondrial disease used to be viewed as being quite rare and esoteric, but now we do know that based on very robust epidemiological data that has been done in the Northeast, that the minimum prevalence of mitochondrial disease is about 1 in 5,000. So it is the most common form of neuromuscular disease in the population in this country. And the reason why I became increasingly interested in mitochondrial eye diseases is because in your typical mitochondrial clinic, more than half the patients that come to see us will have some form of eye involvement. And the most important involvement is obviously if someone starts to lose vision, because this is one of our most precious sense. And I'm not going to talk about the other forms of eye involvement. I'm going to focus on optic nerve involvement. And really, the classical mitochondrial disease which causes optic nerve damage and loss of vision is Leber's optic neuropathy, or LHON. But before I talk about LHON, there's another concept which I want to introduce here because it's relevant in terms of diagnosis and also in terms of your risk of losing vision. And this is something which is known as heteroplasmy, because this has relevance to the energy threshold of your mitochondria, right? So I've already mentioned to you that each mitochondrion will contain their own mitochondrial DNA molecules. Within a cell, it's a very high copy number genome, so you can have thousands of copies of these mitochondrial DNA molecules. And at one extreme, all of them are 100% wild type. By wild type, this means there's no mutation. At the other extreme, all the mitochondrial DNA molecules are mutated. But in between, you can have a mixture of the normal and the mutant mitochondrial DNA molecule. And the reason why this is relevant is because as you start to accumulate these mutations, Mother Nature has given us a degree of redundancy. So as the mutations accumulate here, you're able to maintain the amount of energy being produced, and you don't have any medical problems. But then you reach a critical threshold. And when you reach that critical threshold, you start to overcome this compensation, and very rapidly, there's a reduction in the amount of energy being produced by your mitochondria and by the cell. And that's when disease starts to appear because you're losing that capacity. And in the context of LHON, we know that if you have a mutation level which is less than 70%, you're in a safe zone because you're not going to lose vision. And the problem with LHON and with other mitochondrial diseases is once you've reached that critical threshold, once you basically stop to produce enough energy, it's an irreversible cycle. And very rapidly, all these death pathways will be triggered, and the cell will be programmed to go towards programmed cell death. And unfortunately, your retinal ganglion cells within the retina is exquisitely sensitive to any disturbance of energy. Because if you think about this, all the time light is going to the eye, all the time the retina is producing signals. It's a very highly energetic piece of tissue, and it needs to have energy there at optimal level. So what about Leber's optic neuropathy? I'm just going to talk more about the clinical features now, right? So the disease is named after Theodor Leber, right? He was a German ophthalmologist. He worked at Heidelberg University Hospital, and he's very, very much viewed as the father of modern European ophthalmology because there's other conditions named after him. One condition which can cause confusion is something called Leber's congenital amaurosis, which tends to affect children with very early loss of vision. So Leber's congenital amaurosis is completely different from Leber's optic neuropathy. And sometimes patients and families will contact me when actually their children have Leber's congenital amaurosis. At Moorfields, where I also work, there are experts there who are focused on this other condition called Leber's congenital amaurosis. And it started a very long journey of research. Theodor Leber was a very sharp clinician. So in that paper published in 1871, he described 4 families that he recognized the key features of Leber's optic neuropathy. The first feature is it tends to affect young men. The second feature, it only is transmitted down the maternal line. And the third feature is that, unfortunately, the visual prognosis is quite poor. And rightly so, the condition has been named after him. And then the other major breakthrough happens in 1988, which is really the birth of mitochondrial medicine. And this guy here, Doug Wallace, identified that in families with Leber's optic neuropathy, there was a specific mutation within the genetic code in your mitochondria located at position 11, 7, and 8. So this really started the diagnostic process for Leber's optic neuropathy because now we had a way of confirming what used to be a clinical diagnosis. And from a clinical perspective, we do know that 3 mutations within the mitochondrial genome account for the majority of cases. And these mutations are known by their numbers within the mitochondrial DNA molecule here. So the 3 main ones are 3460, 11,778, and 14,484. And in this country, and in most countries of the world, 11,778 is the most common mutation. The exception is if you're in French Quebec, where 14,484 is much more common because of a founder event. So the rough distribution is 60% for the 11,778 mutation and 15% each for 3460 and 14,484. What about the other 10%? Well, if I suspect that someone has Leber's optic neuropathy, we will send a blood sample to the lab and it will test for these 3 mutations. If it's negative, then they need to screen the rest of the mitochondrial genome to try and look for rarer mutations. And again, this will change with time because now genetic technology has moved on, and it could be that very soon, we'll be able to just sequence the whole mitochondrial genome from the start, and we don't have to do a 2-step process. As always, there's a cost attached to this, but that's something that needs to be dealt with in terms of financing rather than in terms of the scientific basis. So what about the prevalence of Leber's optic neuropathy? The advantage that we have here in the UK is that it's a good place to do epidemiological studies because it's quite easy to trace back families. Certainly in the Northeast, a lot of families will stay in that part of the world. So we find it's a very useful resource in terms of establishing the prevalence of various diseases in that part of the world. The figure that we have for Leber's optic neuropathy is 1 in 27,000. So it's a rare disease, but certainly not as rare as AKU, as Nick mentioned already in his presentation. And this was not the first study that we did on the epidemiology of Leber's optic neuropathy. We published a paper back in 2003, which was based on the prevalence of affected LHON carriers in 1998. And that was essentially the start of my involvement with the mitochondrial world. This is basically, we used to do a clinic in Newcastle with Patrick Yu and with my old friend and mentor, who's also an ophthalmologist called Phil Griffiths. And by having this dedicated clinic and by having this network of families, we're able to derive the prevalence in the northeast of England. And at the time, we got a value of 1 in 31,000. So essentially, fast forward 10 years, the prevalence has remained stable, and it's more or less around 1 in 30,000. So how do patients present with Leber's optic neuropathy? It's a pretty dramatic presentation because almost overnight, someone will present with loss of vision either in one eye or in both eyes. In about 25% of patients, both eyes get affected at the same time. In the remaining 75%, one eye is affected first, and then the other eye becomes affected normally 3 to 6 months later. So it's always a bilateral disease, either right from the start or the second eye becomes affected a few months down the line. And unfortunately, there is severe reduction in vision. Most patients, by the time they come and see me, will be unable to read the top letter on your standard chart. And in terms of the group of patients that tend to get it, the peak age of onset is between the age of 20 and 30. So it's a disease of young adults. Obviously, there's a spectrum from children to older patients, but this is a disease of patients in their 20s and their 30s. And if you carry one of these mutations, and you have not lost vision by the age of 50, then you're in a much safer zone because 90% of patients that are going to lose vision will do so before the age of 50. And this is the big mystery, really, because I've already mentioned to you that these mitochondria are present in every cell in the human body. But for reasons that are still unclear, these retinal ganglion cells within your retina are affected preferentially, right? And we're trying to understand why that is the case. It's proving quite challenging because it's difficult to get a hold of human retinal ganglion cells, and that's a topic for another presentation. But this is really the key feature, really, that these retinal ganglion cells are affected preferentially, the optic nerve starts to get damaged, and you start to lose vision. And there are very few conditions that can result in this very dense loss of central vision, what we call a central scotoma. And every time you have someone coming to your clinic with this clinical presentation, you have to think about Leber's optic neuropathy. And it's also part of the education we need to do for younger trainees, that they need to think about rarer diseases when they are faced with a young person who's lost vision in one or both eyes. So I just want to show you a very quick example of someone who was 21 at the time that he came to clinic. And here you can see the visual field here. In the left eye, which is still normal, you can see that it's whitish in appearance, meaning that it's normal. In the right eye, which has become almost completely dark, this is the central loss of vision I've just mentioned to you, right? And this is in December 2007, when the right eye has been affected for only 3 months. Now, 4 months down the line, the left eye starts to become affected. And you can see here, the dark spot is appearing here, right? And the vision is starting to drop. And 4 years down the line, there has unfortunately not been any improvement in his vision. And you can see here how both eyes have been affected, with the right eye being much more severely affected. And this is part of the problem, because we do know that the optic nerve is the one which gets the greatest hit in Leber's optic neuropathy. And now the challenge is how we can target treatment to promote survival of these retinal ganglion cells and improve function. And we'll talk more about this in the afternoon session. And the other thing that you will hear about, that you will see in your letters, I always send my copy of my clinic letters to patients, is this term optic atrophy, right? So as the optic nerve becomes damaged and as you start to lose your retinal ganglion cells, the optic nerve changes from this nice golden yellow appearance to this very pale appearance here, right? And this pallor of the optic nerve is what we call optic atrophy. And that's really the unfortunate news about Leber's optic neuropathy. It's a disease which affects both eyes. You lose vision very quickly, and unfortunately, the majority of patients will not get any significant visual recovery. You can get some visual recovery, it's incomplete, and the best prognosis is with a 14484 mutation. And practically speaking, invariably, most of the patients that will come to see me in clinic will have been registered as being severely sight impaired, what we used to call as being blind registration. I did mention that there are exceptions to the rule of this being a disease of young adults, because about 20% of LHON carriers will lose vision before the age of 12 years old. And the reason I'm mentioning this is because certainly in London, I do get a lot of referrals from Great Ormond Street. And we did a study recently done by Anna Magenda, who's now back in Helsinki. And the reason why I wanted to do this is because our impression was that children behave differently from adults in a good way. Because what happens in children is that the disease can progress much more slowly, and it actually carries a much better visual prognosis. So if you have a LHON mutation and you lose vision before the age of 12, you're much more likely to recover good vision. So that's something that we can give to parents and give them hope that the vision can improve with time. And if you want to read about this, the actual full paper was published only recently, this year in the British Journal of Ophthalmology. So that's the clinical features of LHON, right? And this is a really difficult question, really, right? What triggers loss of vision in Leber's optic neuropathy? Because if you carry the mutation, if you're a carrier, this does not mean that you're going to lose vision. This is a figure which you will see in a lot of papers, including those that we have published, that if you're a man, your risk of losing vision is about 50%. And if you're a woman, your risk is about 10%. This is a ballpark figure, and the thing to stress is that there's a big variation both within families and between families. But what these figures tell us are two very important observations that Theodor Leber actually spotted in his description back in 1871. The first thing is there is incomplete penetrance, and what this technical term means is that having the mutation, you're not 100% assured that you're going to lose vision, which is a good thing. And the second thing is the marked sex bias, because if you're a man, your risk is about 5 times higher than if you're a woman in terms of losing vision. So what it tells us very clearly is that there must be additional factors that trigger loss of vision. Having the mutation is essential, obviously, but it is not enough in itself to trigger the loss of these retinal ganglion cells at the back of the eye. So what are these additional risk factors? So with my friend Patrick Yu Wai Man, we spent nearly 15 years trying to understand this, and we have some answers, but not all the answers that we would like to have. So this is just a little cartoon here, really, just to show you the complexity of this disease. So here you have your little mitochondria with the mitochondrial DNA here sitting in the middle. We do know that the primary reason you get Leber's optic neuropathy is because of a mutation. But what we do know is that there are other factors at play, other factors within the mitochondria, other factors within the nuclear genome, and also environmental and hormonal factors. And the reason why there are other factors at play, I've already mentioned one of them, is not everyone will have 100% level of the mutation in their cell. So if you're heteroplasmic, i.e. there is a combination of the normal and the mutant molecule, you might be lucky. Because if the level of the mutation is low, say less than 70%, then you're in a safe zone, you're not going to lose vision. Whereas if you have a high level of the mutation, then you have the risk that you will have based on your other risk factors. But the other important point I need to make here is that 90% of carriers will have very high level of the mutation. So heteroplasmy can't explain most of the reasons why you will or you will not lose vision. The other big factor that we think might be relevant is whether there are other genetic factors at play in your nuclear genome, right? So I mentioned that the mitochondria have their own genome, but actually most of our genetic material is present within the 23 pairs of chromosomes that we have, the 3.2 billion base pair of the human genome. And the chromosome which has attracted a lot of attention is the X chromosome, right? The reason for this is because a man will have an X chromosome and a Y chromosome, whereas a woman will have two X chromosomes, right? So there's a fundamental difference between men and women in terms of our genetic makeup. And the theory goes that you have a risk factor on the X chromosome, and this risk factor in combination with the mitochondrial DNA mutation will lead to visual loss. So an easy concept, and I'll introduce Sarah Nesbitt later on, but she's a PhD student working with us here in Cambridge and also in Newcastle. And one of the things that Sarah is trying to understand is whether we can model the families and get a better understanding of the genetic model we should be using. And this has been very challenging because so far, after all the energy, all the money has been invested into understanding the genetic risk factors, we still haven't found anything on the X chromosome which can explain why men are more likely to be affected than women. It's a combination of many things. Perhaps we don't have enough power, we don't have enough families to study, and that's something that I will discuss in more detail this afternoon about the other research studies that are ongoing now, trying to understand the genetic risk factors for Leber's optic neuropathy. The other important risk factor, which is relevant because you do have some degree of control over this, is the role of environmental and personal factors. And this is a study published now back in 2009 by Matt Kirkman, who was a medical student working with me and with Patrick Chinnery. And this was a reasonably big study where we look at 125 families with a confirmed diagnosis of Leber's optic neuropathy, and we interviewed roughly 200 affected and 200 unaffected LHON carriers. And what was quite striking is that when we look at smoking habit, if you're a light smoker, your risk of losing vision was increased by twofold. If you were a heavy smoker, your risk was increased by more than threefold. So clearly, smoking is strongly associated with an increased risk of visual loss. It's not very easy to tell people to quit smoking, but at least that's something you can tell other family members that they should consider doing, because this is a way of reducing your risk of losing vision. In terms of drinking, there was a suggestion, but this was not as significant when we did the multivariate analysis. And I'm not that strict when it comes to drinking, as long as you keep it to a reasonable level. So why should smoking increase your risk of losing vision in Leber's optic neuropathy? Right? Well, there are many reasons for this. The first reason is that if you smoke, there's less oxygen floating in your blood. And if there's less oxygen floating in your blood, there's less material for your mitochondria to produce energy. Simple as that. The second factor is that in smoke, there's a lot of toxins. And some of these toxins poison complex 1, which is crucial in terms of the mitochondria producing enough energy. And the toxin is cyanide, and we know that cyanide will block complex 4, right? So less oxygen, toxins that block the mitochondrial respiratory chain, and then in the right context, you're going to lose vision. And then what is the other fundamental difference between a man and a woman, right? Well, we already talked that we all get our mitochondria from our mother. But the other fundamental difference are hormonal factors, because women will have much higher levels of circulating estrogens and progesterone. And this work done by the group of Valeria Carelli in Bologna showed, at least in vitro in a cell model, that estrogens were neuroprotective. So if you have higher level of estrogens in your circulation, this might protect your retinal ganglion cells. And the reason why this is also relevant is when you do studies of the retina and you stain your retina for antibodies that can target these estrogen receptors, there are very high level of estrogen receptors in your retina. So this is a big debate, really. This has been studied in other diseases. The question is whether you can use this concept to protect the optic nerve, right? And it's not easy because obviously you can't give men estrogens because they're going to get feminizing side effects, but there might be a way of modulating estrogen-like molecules to try and protect the optic nerve, and that's something, again, which needs further work as we move forward. So the take-home message here really is that you absolutely need a mitochondrial DNA mutation to have Leber's optic neuropathy, but it is definitely a complex disease. And there are still a lot of things that we have not deciphered yet, and the most important one, really, are the other nuclear modifiers, because if we don't know what are the other risk factors, we can't give a person an accurate risk of how likely they are going to lose vision, except for the fact that we can say that men are more likely to lose vision compared to women, and as you grow older, your risk becomes less and less. So the final topic is really about the other clinical features that you can get in Leber's optic neuropathy, because this is obviously a major concern. You've already lost vision in both eyes, which is a major handicap. Now, if you go into Google, you'll find reports of other patients with LHON developing more severe neurological problems. And this is a very frequent question I get asked in clinic, rightly so, because people want to know. So to the question of whether the optic nerve is the only target in this disease, the bottom line is yes. In the vast majority of cases, if you have a LHON mutation, only the optic nerve will be affected, and visual loss is going to be the only clinical feature that you will develop. But as always, there are exceptions. And again, if you read all the papers that have been published over the years, in addition to optic atrophy, there are other clinical problems that have been reported. Brain problems, muscle weakness, problem with your peripheral nerve, hearing loss, and cardiac problems. And now you need to put your critical hat on, because although some patients can develop these features outside the eye, it's very difficult to know whether this is causally related or whether this is just a coincidence. So this is a paper here by Eva Nikoski-Leinen, who's retired now, but she was one of the early figures of research into Leber's optic neuropathy, and she coined that term, LHON plus or Leber's plus. And I think the point to make here is that because LHON is a rare disease, it's very difficult to be 100% sure that an association is causal. But the one where there's probably more evidence is in relation to some of the brain problems that you can get, right? So this is a neuron. This is a typical cell that you will find in the central nervous system. And the important thing about neurons is that they have something called a myelin cover, right? And the analogy here is that if you think about a cable, an electric cable, for example, it has a coating around it. The coating has an important function. It protects the nerve, and also it allows a signal to be transmitted much more quickly. So again, taking this analogy forward, in a disease like multiple sclerosis, for example, the myelin sheath gets damaged. And because the myelin sheath gets damaged, you're less able to transmit these signals quickly, and this leads to problems within the central nervous system. And I also see patients with MS in my clinic, and about 40% of patients with MS coming to a clinic will get eye problems, and they will get something called optic neuritis, which is inflammation of the optic nerve. And the reason I'm mentioning MS and the reason I'm mentioning optic neuritis is because of this paper published in 1992 by Anita Harding, who was a very well-regarded neurologist based at Queen Square in London. And she wrote this paper with Alistair Compston, who until recently was the head of neurology here in Cambridge, who is a world expert in multiple sclerosis. And what Anita Harding published in that paper back in 1992 is a very important observation. She described 8 female carriers carrying the 11 778 mutation, and all these 8 women developed a feature that was very similar to multiple sclerosis, in addition to losing vision in both eyes. So what we did is we did a much bigger study of what is labeled now as either Harding's disease or LHON-MS overlap syndrome. And what we now know is that this is not limited to only the 11 778 mutation, but you can also get this with the 3460 and the 14484 mutation. And again, this is rare, but there is good evidence to suggest that there is such a thing as a LHON-MS overlap syndrome. But the one thing which I can reassure you about is that based on our data, there is no evidence that there is an increased risk of developing MS if you're a carrier of a mitochondrial DNA mutation that causes LHON. Thank you very much.
Thank you, Patrick. That's great. Now, we've deliberately left a good amount of time for questions because it's a great opportunity for people to ask questions. Can I ask those who have questions to raise their hand so that we can get a microphone to you rather than shouting out the question before we get that in place? So, any questions, please, for Patrick? Let me start with Krista here.
Did I understand you right that you said that the risk of getting LHON was less if you have less than 70% of mutated mitochondrial cells?
Yes, it is based on a retrospective study, right? The first thing to remember is that 90% of carriers will have nearly 100% of the mutation, right? But in about the 10% of carriers that have less than 100%, if you have a level which is less than 60 to 70%, then your risk of losing vision is almost zero, really, right? Because you've not reached that threshold that is sufficient to compromise the amount of energy being produced. But in the bigger picture, if you take 90% of carriers have 100% of mutation, right? Only 10% have so-called heteroplasmy. Heteroplasmy in itself can only account for a very small proportion of why you don't lose vision, if I'm making sense.
I have 50%, so I'm very rare.
The other thing that you also need to consider, and that's why it's a small retrospective study, is if I test your blood, right, for the level of the mutation, it's telling me the level of the mutation in your blood. There's been studies before where they've studied the level of the mutation in blood, in other tissues, including the retina, and they found that actually there can be big differences. So you could have 50% in your blood, for example. It's speculation, but it could be that your retinal ganglion cells have 80% or 90%, right? Obviously, it's very difficult to do that, right? But this has been replicated in cell model that the level of the mutation will impact on how much energy is being produced, right?
Speaking of the bigger picture, I see you must be feeling homesick, Patrick. You've got a picture of your old home, not the current one. Next question.
I spent a lot of my life and career there, and it's actually a great place. Now, it's there's much to be said about Newcastle and the North East, except for the colder weather.
Okay, next question, please.
Are there any theories as to why the 14484 mutation is more likely to present visual recovery?
That's an excellent point. And the group of Valeria Carelli have done some very nice work on the biochemical aspects of these various mutations. I'm not a biochemical expert, but if I scroll back perhaps to an earlier slide, right, okay, let's take this slide, for example, here, right? So if you look at your mitochondria, you have these complexes here. There's 5 of them, 1, 2, 3, 4, and 5. And what happens is you have these electrons that flow from 1 to 4, and the energy release is used to produce ATP, which is basically the energy currents in your cell. And these mutations are located at different positions in this complex 1. And depending on the position of the mutation, it disrupts the interaction at different levels. And that's why it's thought that some mutations are, quote unquote, a bit more benign compared to others, right? So you still have a compromise of energy, but it could be that the 14484 has a much lower impact in terms of the flux of electrons.
And more questions? We had quite a few more hands at the
There's
beginning.
plenty of time.
Hi, I'm Annette. I am a patient of Patrick Yu Wai Man's. I just wanted to ask you again about, you said about estrogen levels affected people. I've got the 11778. I just wanted to know, I lost my sight when I was 47, so it was premenopausal. Was that due, did I lose my sight because of my estrogen levels going all over the place because of menopause? And also, I have a 15-year-old daughter. If you're a carrier, would the female carriers, will it be of benefit for them to take estrogen?
2 very good questions, and I will tell you what I think and also the big gap in our knowledge. So there's that study that was published by the group in Bologna about estrogens being protective, and what they did, they collected small skin biopsies from patients who carried the mutation. They grew the cells in tissue culture in a petri dish, and then they treated some of these cells with estrogen derivatives. And they found that treating them with estrogens and other estrogen derivatives protected the cells against cell death, right? So it's interesting, but remember, it's a petri dish experiment. Now the question is whether or not around the perimenopausal period, there is an increased risk of losing vision if you're a female carrier. About 2 or 3 years ago, we looked at our data, right? And there was no obvious, a peak of women losing vision around this perimenopausal period. Because this is what has been raised, whether, at least theoretically, it could be that if you're a woman, around that time, it's a bit of a second danger zone, really, right? And it is not a definitive study because we only look at the families in this country, and probably you will need a big international study to do that, to be able to have any signal of whether, this is a risk factor. The second thing is, if you're perimenopausal or you're menopausal, should you or should you not go onto HRT, for example, right? I personally don't feel that there is enough evidence for a female carrier to go onto HRT unless there are other good reasons for this, because there are side effects to taking any treatment. This is a discussion that should be had with the GP, but I personally don't promote or advocate someone going onto the HRT if there are no other reasons for it. The usual reasons being bad perimenopausal symptoms. The other question about your daughter who's 15-year-old, well, nature's on her side because she has very high levels of circulating estrogens and progesterones in her blood, and there is no indication for this at all.
That's good. I'm not going to get my daughter on estrogen just yet. But I also would like to point out that my grandmother also lost her sight age 50. She was obviously a female carrier.
Right. And it's difficult for me to make additional observation, but, and again, that's something we will touch upon in the afternoon presentation, is very often we describe the most common scenario, right? But there are also scenarios of carriers losing vision in early childhood, carriers losing vision much later on in life. And if you read the literature, there are other risk factors that have been mentioned, for example, head trauma. Now I have seen quite a few carriers in my clinic where it seems that they've had a significant head trauma and then they lose vision shortly afterwards. Is it truly causal? I don't know, but perhaps now, having been in practice for quite a long period of time, there might be something in there in terms of head trauma. So it's difficult. When it comes to a rare disease, very often we end up with isolated anecdotal reports, and it's by accumulating these with other collaborators that we can get a much clearer picture, really.
What's the research behind why there's so many different medications on the avoid list?
Right. So again, this should be viewed as being a relative contraindication. What this gentleman was referring to is, we do know that there are some drugs that can affect mitochondrial function. Because if you think about this from an evolutionary perspective, in early development, right, you had a cell that basically engulfed an early mitochondria, right? And then gradually, this symbiotic relationship matured, and the mitochondria was there to produce energy, right? But if you think about it, we have within our cell a kind of bacterial derivative, right? So a lot of the antibiotics that we use actually target specific mitochondrial proteins, right? So theoretically, there are some antibiotics that might be detrimental to mitochondrial function, especially some antibiotics that are used to treat tuberculosis, right? And certainly, I would avoid these if possible. But if someone has a life-threatening condition that requires using a specific antibiotic that could have an effect on mitochondrial function, that takes precedence over some theoretical increased risk. And the list goes on, right? But I think that's the one thing where you have to have a discussion with myself and with the doctor looking after you as to whether we're talking here about an absolute contraindication, which there are very few, and more like a relative contraindication.
Okay.
You mentioned about is it Harding's disease and about muscle weakness. Is this something that's quite common among LHON patients?
No, and again, this is something which I mentioned in one of my slides, is that definitely there are patients with Leber's mutations that will develop other features besides the optic nerve, but these are relatively rare. But there's no doubt that there are some combinations that are well reported. I've mentioned the combination with multiple sclerosis. There are also other patients that will develop dystonia, or you mentioned sometimes people can get muscle weakness, but these are relatively rare. And perhaps in my practice, because I've had the chance to work with neurologists, Patrick Yu Wai Man in Newcastle, we do see more of patients with more severe clinical presentation just because of the referral bias, really. But at Moorfields Eye Hospital, for example, in London, I can think of a couple of patients, right? But all of them have the classical bilateral loss of vision. So it's very much perhaps where you're doing your clinic and with whom.
Okay, great. Any more questions? Any burning questions?
So, you mentioned that obviously, occasionally, or quite often in the early stages of Leber's, people gain back some sight. is there any thought as to why people might gain back some sight? Because obviously the mitochondria itself aren't getting any more energy. So is there any thought as to why there is some recovery in the early stage?
Oh, absolutely. I think it's a really fascinating area, really, and which we're trying to study more. So there are a few theories, right? So I'll go through them with you guys. So what happens in Leber's optic neuropathy? I mentioned that you have roughly around 1.2 million retinal ganglion cells. When the disease starts, whatever the trigger might be, you very quickly lose a lot of retinal ganglion cells, right? So it's a very, very quick cataclysmic kind of the drop, right? But then you have a proportion of these retinal ganglion cells which are not working properly, but they are not quote-unquote dead yet, right? What I call being in suspended animation, right? And a lot of the treatment that we're hoping to use, whether idebnon or otherwise, is to try and rescue these cells that are not dead yet, but that we could potentially bring back to life, right? So there is certainly a proportion of these retinal ganglion cells in the acute stage that we can hope can recover function either spontaneously, right, or hopefully by giving them a bit of a kick with some form of treatment. So there's that population of retinal ganglion cells that are at a stage where they are still able potentially to survive. The second theory is, as I've mentioned, your optic nerve has a covering of myelin. And in LHON, the myelin gets damaged, right? But the myelin can be reconstituted. So it could be that you lose vision, 9 months, 12 months down the line, some of the myelin forms again, the signal goes down the optic nerve much better, and then you're able to see better. The third theory, again, which is valid, is that you become much better at using your eccentric fixation, right? i.e., people are smart, the brain is smart, so it finds ways of going around this central loss of vision. So eccentric adaptation. The fourth theory, which we hope to do very soon, is whether there is plasticity within the visual cortex. So could it be that the brain is able to gradually rework its network to bypass this middle area where you can't see properly? So you basically open up new pathways of analyzing the data, right? That has not been done probably because you need to do a powerful MRI called a functional MRI study, which is expensive. Everything we do is expensive. But that's something which is definitely worth exploring, because the questions you ask me is highly relevant in terms of how we develop treatment and how we choose those that might benefit from a specific treatment.
So I wanted to ask a question about how it's. So I wanted to ask a question about how it's transmitted. Is it always that it's going to be passed down from the mother, or could it be that you get a mutation that's just kind of occurs by itself in an individual patient?
We do know that, and again, this is an interesting observation, because the good thing about the UK is that it's really easy to do contact tracing. So based on our own data, I'm only aware of one patient where we showed very clearly that it's a de novo mutation, meaning that the mutation arose in the egg, and therefore when we check other family members, we can't find a mutation, right? But in the vast majority of cases, these are all mutations that have happened centuries or millenniums ago, right? And therefore, everyone will carry the mutation, really.
So then just as a follow-up question, is it possible, so you talked before about there can be massive variability in terms of the chances of it actually triggering in people. And so what is the sort of range on that? So say in our family, we have no history of it at all. We've just got one person basically where it's...
And that's again something which we'll touch upon here, is that you can look at two families, right? I'll show two very striking examples where you have one family, right, where there's a single affected male carrier, right? No one else is affected, but they all carry the mutation. So there must be other genetic risk factors involved here, right? Whereas we have another family where almost everyone loses vision and at a very young age, right? So it can't be just about having the mitochondrial DNA mutation, right? It can't just be about environmental risk factors, right? But how do we then put all this together? It's a bit of a headache because obviously we need to control for smoking. We need to control for the level of the mutation. And that's why these bigger genetic studies are needed. And I will mention this because it's a collaborative work that we're doing and with Patrick Yu Wai Man and members of his group. And it's a very difficult task. And I think what we need as part of what we're trying to establish is having a wider network of LHON organization that would allow us to collect enough blood samples to do this much more sophisticated analysis. But you're correct, Lynette, that there is a huge variation, right? And if you're somewhere like in the US, for example, they have more so-called sporadic cases, but it's not really sporadic. It's just because in somewhere like North America, people move around more. People don't go back that far in terms of tracing back their lineage. And what is thought to be sporadic, actually, if you're able to trace back, you might find a distant uncle, a distant relative that might have lost vision. And in some countries of the world, like in Europe, for example, like in Denmark, right, they've been able to trace all their families over centuries, really, and it's amazing.
Last question, I think, please.
Hi, just following on from the gentleman's question about spontaneous recovery, is there any understanding why that is better in childhood?
Yes, right, okay, so I don't have the answer to this. And one of the studies that one could do is to get enough blood samples from children who lost their vision before the age of 12, and then compare this group with your more classical group of young adults who've lost vision, and see whether or not there are any genetic protective factors that might explain why children do better, right? There's no real good explanation for this. And I think probably children, carriers who lose vision as children probably have a better risk profile from a genetic perspective. But then it's easy for me to say, here, let's do the study. But even in a national cohort in the UK, we can only assemble 30 or 40 patients, right? And we would really have to collect blood samples from all across Europe and Asia and North America to be able to do such a study. It's difficult. People are willing to do it, but you have barriers. You have to get ethical approval. You have to get funding. But these are aspirations. We need to understand why some groups of patients behave differently from the textbook description.
Thank you. And for those people who find diagrams like this impossible to understand, don't worry, you're not alone, because most of us really struggle to even understand the basics. But we don't have to understand it all. Patrick's going to be here this afternoon. He'll be here over lunch. If you do get people with questions at lunch that are relevant to everyone, Patrick, if you can try and store them, and perhaps we might weave them into this afternoon's discussion where possible. But thank you, Patrick, for a great presentation.